and welcome to another episode of the Fertility Podcast. I'm Natalie, your host, and I've got a bit of a confession to make because as you're listening to this, I will be in Spain. I have gone on a little girls' holiday and I've been really organised, and I've recorded this in good time so that it will land in your ear hole for your Monday morning commute to work or walk to work or dog walk or however you are listening. Now, whilst I'm taking advantage of a little bit of time to myself, I just want to ask one little favour, which I'm just going to come right out and say it because it would be amazing if you could rate and review and subscribe and share this podcast. Now, one thing that I've not been great at is urging you to review this podcast, but if it's helped you in any way and you do send me messages saying that it has, it would make such a difference. I haven't counted the number of reviews that I've got, but I've seen other podcasters in this space asking for your help in getting them to a certain number. I'm not going to be so specific, but it would be lovely. It would be lovely. Do you know what? I am. Let's see. Right. Hold that thought. Okay, brief interlude there as I just went and looked on iTunes to see how many ratings that I've got. 115. Can we get to 150? Can we do it? Right, all you need to do is just in your favourite podcast app, rate the podcast. 5 stars is always lovely. A review is amazing, but the 5 stars, go on. Just bang, 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 bang. It's very easy to do, and that will make me feel really loved whilst I'm giving myself some TLC in Spain. Now, it's September, if you're listening in real time in 2019. It's PCOS Awareness Month, and I'm really lucky in that I get to co-host this podcast in its new guise, which I'm sharing on UK Health Radio with Kate Davis, who is a fertility nurse, and she specialises in helping women dealing with PCOS. And Kate has got this amazing PCOS journal that she's launched, and she will tell you more details about it. We also talked to Professor Adam Balin, who is another specialist in PCOS. He's based in Leeds in the UK. Kate and him used to work together, and between the pair of them, they know a lot about PCOS. So if this is something you're struggling with or you're wanting to understand more, then this episode, I'm sure, is going to be super, super helpful for you. So I'm going to shut up. Keep listening to the end so you can get the show notes details. Be sure to follow me on Insta or Twitter at FertilityPoddy. There's the closed Facebook group, which is Talk Fertility, which you can join. And also the Facebook page is the Fertility Podcast. Loads of ways to get in touch. And I'll be back very soon. Hello and welcome to Talk Fertility, a show where we do just that, talk about fertility. I'm Natalie Silverman, host of the Fertility Podcast, which I launched in 2015, once successfully pregnant after having fertility treatment.
And I'm Kate Davis, a trained fertility nurse and founder of Your Fertility Journey, where I work one-to-one with women and couples to help them understand and optimise their fertility.
So, I'm really quite intrigued as to how this next conversation is going to pan out, because it's with an expert who I've spoken to in the past, someone who, Kate, you've worked with in the past, but it's about a topic very close to your heart because we're speaking in September. It is PCOS Awareness Month, and PCOS is a big part of the work that you do, isn't it, Kate? It's something that I really want to kind of talk more with you as well as our expert about because of your experience and your wealth of knowledge.
Yeah, I got really interested in PCOS and first started to understand more about it when I worked at a gynae clinic in Oxford, where Adam was actually a registrar at the time and I was a senior staff nurse. So this is about 20 years ago, probably a long time ago. And we had a lot of PCOS patients and I really found it quite fascinating understanding the condition. And the more I understood it, the more I understood it's not just cystic ovaries, but it's just such a complex condition and one that is really poorly diagnosed in the UK. It takes a long, long time to diagnose it. There's just so much that you can actually do to improve PCOS. So whilst you can never completely get rid of the condition, there's so much that you can do to improve the symptoms, improve lifestyle, improve the management. So it's quite a fascinating area. And I actually love working with women with PCOS because it's probably quite a rewarding area. When I start working with women over a period of months, you can see how their PCOS improves and how we can optimize their fertility, how they're less likely to have the side effects that can be associated with PCOS. So it's quite a rewarding area in which to work in.
And one of the things you were keen to talk with Adam Balin, Professor Adam Balin, who is our guest, who we're going to be speaking to soon, is new guidelines on PCOS. And I was wanting to ask you, are these UK specific or would they apply wherever people are listening?
They're actually international guidelines and they were developed in 2018. They are incredibly comprehensive. I think it's about a over 200 page document. Yeah, so they're actually international evidence-based guidelines and they were developed in 2018 and Adam Balin was part of the development committee. But they are incredibly good guidelines. They give out so much information for the assessment and management of polycystic ovarian syndrome. However, I still see that they're not always utilised in general practice. And I'm forever signposting my patients to them so that they can get informed, get knowledgeable, and take the information into their GP and talk to their doctor about how best to diagnose, assess and management their PCOS so they can be really informed of their condition.
Okay, well, we can quiz Adam a bit more on it. And also we're going to be talking about the common issues and the misconceptions. And if PCOS is something that you have been diagnosed with or you're wanting to understand more about, then I really hope this will be useful. And I have also spoken with Adam and Kate on this topic in previous podcast episodes, as well as a couple of PCOS specialists who talk a lot about diet and lifestyle changes. And I'll share some links to those podcast episodes because I think they'd be quite interesting reference points for you. So we're now going to welcome Professor Adam Balin to Talk Fertility. He's a full-time consultant in reproductive medicine at Leeds Training Hospital, as well as doing a lot of other stuff. Adam is pretty busy and quite hard to pin down, as well as being involved in the British Fertility Society. You were involved, Adam, earlier this year in the first Fertility Forum event, weren't you? And it's a pleasure to have you here.
Yeah, well, thank you very much, Natalie and Kate. And it's great to be invited and to talk to you. And yes, I mean, the Fertility Forum was a fantastic event. And for those who don't know, there are all the videos of the talks that are available on the RCOG website. So it's worthwhile going to the patient pages on the RCOG website and looking for the Fertility Forum, where you'll see me talking about PCOS and lots of other great people
we'll
talking
share the
about
link.
all sorts of other things, yes.
So Adam, I'm really intrigued to talk to you about the international guidelines, which I know you're involved with, and you actually very kindly sent me. It's incredibly well written. It's a massive document. It took me ages to read through it.
Yes.
But it's really, I found it really interesting and I use it all the time. So are there any particular major changes that came out of that document back in 2018 when it was published that were different from before?
I think the key thing is the use of Letrozole, which is a tablet to stimulate ovulation. So polycystic ovary syndrome is very common. It probably affects a good 15% of women, but it comes in all shapes and forms. So it's a syndrome. So by that, we mean it's a collection of signs and symptoms. When it comes to fertility issues, the key symptom is of irregular periods. So some women have very unpredictable periods and some women don't have periods at all. And of course, if you're not having regular periods, you won't be having regular ovulations. The issue with the polycystic ovary is it contains many more than the usual number of the tiny cystic structures, which are normally occurring natural structures that contain the eggs. We often refer to them as follicles, and in a natural cycle there will be many follicles at the beginning of the cycle, but only one will grow and ovulate. Women with polycystic ovary syndrome tend to have an imbalance of the hormonal signals within the ovaries and the signals that are important to enable the follicle to grow in a coordinated way. So essentially the ovary sort of stacks up with lots of these tiny little cystic follicles, and that's what you see on an ultrasound scan. Some women, but not all women with polycystic ovary syndrome, have problems controlling their weight, and women who are overweight often have worse symptoms and will benefit from lifestyle changes, weight reduction, and sort of careful nutritional assessment, really, in order to improve the prospects of ovulating naturally and also improve the prospects of ovulating in response to the treatments that we may need to use. So there's a huge amount of interest in lifestyle and a sensible approach to diet and nutritional supplements, and that's covered in the new guidelines. Many people think that there's a PCOS diet. There isn't actually one diet for all women with PCOS, but essentially trying to keep carbohydrate levels low is a good plan, but you need to have a balance of the appropriate amounts of protein and fats, and often seeing somebody with expertise in reproductive nutrition is a good idea. So that's the first thing, and actually that's the first thing for everybody who's trying to have a baby, and that really applies to men and women. And I think it's worthwhile just bringing in men here, because although men won't have PCOS, most women with PCOS who are trying to get pregnant will have a male partner who's probably got similar diet to themselves, similar lifestyle. So it should be a couples thing. So if you're in a heterosexual relationship, couples together should work to improving lifestyle. And if you're in a same-sex relationship, the same applies as well. So improving a general health will improve the prospects of having a healthy home, healthy household, and hopefully a healthy pregnancy. So that's really the sort of the first line. And there's a lot in the guidelines about, how to approach lifestyle, exercise and diet. I appreciate it can sometimes require quite big changes. It's not always easy to achieve, but with appropriate guidance and support and the right sort of advice and the right sources for that advice, I think most people trying to get pregnant are motivated to try and improve things. But even with weight loss and improvement in lifestyle, many women with PCOS will still have irregular periods. Then they will benefit from some form of ovulation induction treatment. And that's really the bulk of the guideline. So the guideline goes into detail, looking at the evidence for the different types of drugs and protocols for stimulating ovulation. And as with most things in medicine, we try to start with simple approaches, and if they don't work, we move to the more complex approaches. So historically, for many years, there's been a tablet called Clomid or clomiphene that's been the first-line treatment for stimulating ovulation in women with PCOS. And it works very well. Hundreds of thousands of babies have been born quite successfully with the use of clomiphene. But in the last few years, another drug called Letrozole, it's a different class of drugs. It's called an aromatase inhibitor, and essentially it's working within the ovary itself to influence the relative balance of the main ovarian hormones. And we're talking here about testosterone and estrogen. So they are the main hormones that the growing follicles make. So women with PCOS often have slightly elevated levels of testosterone. Many people think of testosterone as being a male hormone. It isn't a male hormone. All women make testosterone, and for that matter, all men make estrogen. It's the relative levels that are different. And in fact, you can't make estrogen, which is the main hormone that's important for reproductive health, without first having testosterone. So testosterone gets converted into estrogen, but that process is a little bit wonky in women with PCOS, and so you have relatively high levels of testosterone, and that can have other effects around the body. So classically, it can lead to unwanted hair growth on the face and other parts of the body, sometimes acne, sometimes thinning of the hair on the head, all of which are amenable to treatment, although actually the treatments are often difficult in a woman trying to get pregnant, because a lot of the drugs we use for hair problems can't safely be taken whilst you're trying to get pregnant, or they may even be contraceptive. But anyway, coming back to this drug Letrozole, it tries to correct the imbalance between testosterone and estrogen, and thereby enables the follicles to grow in a orderly manner, whereas clomiphene works in a different way, and clomiphene leads to higher levels of the hormones that stimulate the follicles that come from outside of the ovaries. So here we're talking predominantly about follicle stimulating hormone and luteinizing hormone. So they're the two hormones that influence the developing follicles. They're actually produced by the pituitary gland, which is in the base of the brain, and they travel around the body to then stimulate the ovaries. So you can understand that if you're using a drug like letrozole that works within the ovary to try and correct the imbalance within the ovary, it's inherently going to be a little bit better at trying to restore ovulation in somebody with PCOS. And indeed, the data from a number of scientific publications now have shown that letrozole gives you a greater chance of having a baby than using clomiphene. So this I think is the sort of the biggest change in the new guideline.
So do you find, Adam, that you're noticing more letrozole is being used comparatively to clomiphene? Because I'm still seeing a lot of patients that are on clomiphene, and I love it when I see somebody that's, being prescribed letrozole, but I'm still finding that predominantly it seems to be clomiphene.
I think that's a very good question, and you're probably right, because letrozole is only sort of slowly getting into everybody's sort of mindset. We use it universally here in Leeds for our patients. We sometimes use clomiphene if somebody's got pregnant in the past with clomiphene and they come back and they say, I want what worked for me in the past, then we'll use clomiphene again. But otherwise, we're pretty much only using letrozole. And what I would say to anybody listening, if you are unsure or want your doctor to prescribe letrozole or think about letrozole, I'd be very happy for them to contact me, because I can send through copies of the guidelines and just say it's absolutely fine to use letrozole. Over the years, there's been a bit of hesitation because some people were concerned that letrozole might not be as safe as clomiphene, but there's tons of data there now to confirm its safety. Babies born from treatment using letrozole are healthy babies. And so I've reproduced these guidelines in the UK. I've produced documents for the Royal College of Obstetricians and Gynecologists. So, we are very happy to support any doctor with protocols for how to use letrozole. It's easy to use. It's a tablet you just take for 5 days at the beginning of your cycle. And if you're not having regular cycles, you can have an artificial bleed brought on by a progesterone hormone for a few days. That will bring on a period, and then you take letrozole.
And am I right in thinking, Adam, that letrozole carries a lesser risk of ovarian hyperstimulation comparatively to clomiphene?
That's a good question, and the answer is yes, it appears to be the case. And it was thought that letrozole probably also had a lower risk of multiple pregnancy than clomiphene. The evidence does sort of fluctuate up and down a little bit. And if you look at all of the papers together, the latest sort of conglomeration of papers suggests that there's probably no difference in multiple pregnancy rate. But basically, I think it is a better drug. There are less risks, and it probably doesn't need to be monitored quite as closely as with clomiphene, because this is the other big discussion. Should we be doing ultrasound scanning of the ovaries for everybody who's having either clomiphene or letrozole? I mean, here in Leeds, we've got the facilities to scan, and I think inherently scanning is a good thing.
But it's not very commonly done, is it? That's certainly
no. I mean, I think to start treatment with a series of scans just to reassure you that the drug is working is a good idea. I mean, the other thing is, of course, many people use the ovulation predictor kits to assess ovulation at home, and if you've been using clomiphene, that can give you false positives.
Yeah.
Because clomiphene causes your LH levels to rise. LH is the hormone that is produced as a sort of a surge just before ovulation, and that's what's picked up in most of the ovulation predictor kits. So clomiphene can often give a false reading of that, because the LH levels are often a little bit higher than usual when you have clomiphene. So letrozole doesn't cause that sort of interference with those testing kits. So if you can't get ultrasound, then to use home testing will work well with letrozole as well.
So in terms of, we've talked about the different ways that PCOS can affect people, and we've talked about some of the ways that it can be managed. What still are the common issues and the misconceptions about it? Because we still know there's a lot of narrative from people dealing with it, not being scanned, not being given Clomid, or not being told that there's no point in them having ovulation kits. I mean, what are the common things that you are still coming up against?
Sadly, I see lots of women who've been told they will never get pregnant if they have PCOS, and that's absolutely not the case. There's every reason to feel positive and optimistic if you've got PCOS. Just make sure you get referred to the right clinic and a reproductive medicine unit with sort of specialist expertise. It may take longer to get pregnant if you're having irregular periods, but there's a very good chance you will get pregnant. And even women with irregular periods are having irregular ovulation. So that's the first thing. The second thing is you're overweight because you've got PCOS and there's nothing that you can do about it. Well, it is the case that some women with PCOS find it really hard to lose weight, but again, with the right sort of support and encouragement, and you have to also understand that it's not a sort of a quick fix, but most people can improve their fertility, not necessarily by getting back down to a completely normal weight, but a 5 to 10% reduction in body weight can be enough to make a big difference. I mean, there are eligibility criteria for NHS funding based upon body mass index, and that's sort of kind of controversial, but there is no doubt if you're very overweight, the chance of having a healthy pregnancy is reduced, so you do need to try and do something about that. And then the other thing is, sadly, I think a lot of women with PCOS end up having IVF when they don't need IVF. And that's another big bone of contention, and I spend a lot of time trying to argue for funding for these ovulation induction treatments. They're not as high-tech as IVF. They work very well. Obviously, it's important to check all other components of your fertility. So you need to have your fallopian tubes checked. Your partner needs a sperm test. And if there are problems there, then you may need IVF. But if the tubes are open, if the sperm test is normal, then ovulation induction with these simple tablets is the first line treatment. If they don't work, and not everybody ovulates in response to letrozole or clomiphene, if that doesn't work, then sometimes we give hormone injections of the key hormone that contains FSH, follicle stimulating hormone, the same sort of drugs actually that are used in IVF, although you use lower doses, because here you're just trying to stimulate the development of a single follicle to release a single egg. So that's something called gonadotrophin treatment. Another option is an operation called ovarian diathermy. That's a laparoscopic procedure. So a laparoscopy is a procedure done under general anaesthetic when a scope is put inside the tummy cavity, and it's often used for assessing the fallopian tubes and treating conditions such as endometriosis. And if you've got PCOS, we can cauterize little points on the ovary to try and stimulate ovulation. But again, that has to be done by somebody with appropriate expertise, but that can work very well in certain groups of women with PCOS.
And how frequently is that procedure done, Adam? Because obviously its other name, which puts the fear of God into most women, is ovarian drilling, which whoever thought of that name, really got that wrong.
It's awful.
It's horrid.
Yeah, sure.
But how frequently is the procedure done? Because again, it's not something I've seen routinely.
No, probably not that often, actually. We do it a little bit. I mean, I think the advantage is that you don't run a risk of multiple pregnancy after you've had it done, and therefore you don't need to come for regular scans and monitoring. The downside is it takes longer to get pregnant after ovarian diathermy, and so it's not as effective as using the drug treatments. So it's not done a huge amount these days because the drug treatments are so effective and should be available in most places. The other thing about ovarian diathermy, and obviously any operation brings with it certain risks, so it has to be done by somebody with appropriate expertise. And drilling is I mean, as you say, it's called ovarian drilling, but you only want to do a very little bit to the ovary. You don't want to drill lots of holes. Sometimes you see ovaries that look a bit like the top of a pepper pot because somebody has been a little bit over enthusiastic and burnt lots of little holes in the ovary, and that's really not the right thing to do. So Yes, I think for the right person, performed by the right gynecologist, it can be effective, but it's not hugely commonly performed in the UK.
If you could see the face that Natalie's pulling right now when you're talking about ovarian drilling.
Not just that, but the thought that something could be performed by the wrong gynecologist just fills me with dread. But we'll move on.
I mean, there's an interesting sort of history behind it. Polycystic ovaries are larger than normal ovaries, and so before all these drugs were available, the standard treatment for the polycystic ovary was something called a wedge resection, in which a big chunk of the ovary was removed to try and make the whole ovary smaller. But,
I remember those.
I mean, I've never done a wedge resection. That operation was performed sort of from the 1930s through to the early 1960s.
And I remember talk of them, definitely.
Yeah, I mean, diathermy has sort of taken over from wedge resection because it's a much sort of gentler thing to do, and you really don't want to be removing big chunks of the ovary because, of course, the ovaries contain eggs, and so if you're removing bits of the ovary, you're removing very valuable eggs. I suppose another thing worth touching upon is the use of metformin.
Yes, absolutely.
So, women with PCOS, particularly those who are overweight, have an increased likelihood for developing diabetes, particularly as they get older. That can run in families. It needs to be screened and tested for, certainly before trying to get pregnant. And if you have a tendency to developing diabetes, again, lifestyle, diet, nutrition is the first line to try and improve things. And then the next is the use of medications such as metformin, which is a very effective drug for managing diabetes. And because some women with PCOS have a sort of an early form or pre-diabetes type situation, it was thought that metformin might be a good way to cure PCOS. And in fact, we've published lots of research on metformin. Our first studies we did were in the sort of the mid 1990s. So that's more than 25 years ago we did our research on PCOS, and there have been lots and lots of publications over the years. And we're responsible for the Cochrane review on metformin. So the Cochrane reviews are sort of big scientific publications that bring together all the papers in a particular area. And we've done that for metformin. And the bottom line is that metformin on the whole doesn't do a huge amount of good to improve fertility for women with PCOS. It has a role for those who are developing diabetes. It can sometimes help women who don't ovulate in response to clomiphene, so you can combine it with clomiphene. But there's no hard evidence that it's beneficial for use combined with letrozole or the other sort of treatments that I'm talking about. So metformin doesn't do any harm, can help some people, but sadly it's not the great hope or answer that we thought it was going to be. So we're not using it so much anymore.
Right. So you wouldn't routinely start somebody on metformin now? You've changed that now?
No, I mean, we assess everybody for diabetes and sort of pre-diabetes, and if they're showing signs of that, first approach is diet and lifestyle. If that's not helping, then yes, we may use metformin. And metformin is safe for women wanting to get pregnant, and it's safe in pregnancy as well. But no, it's not a sort of a routine first line. And it was thought also that metformin might help with weight reduction. But the evidence there isn't very strong. Some women love metformin and think it's really beneficial to them. Most experience bowel symptoms, so you get wind and diarrhea and unpleasant bowel type symptoms. So it's not always a nice thing to take. And so, we tend to sort of steer away from it unless there's clear evidence of sort of something like diabetes developing.
Okay. So just kind of backtracking a little bit and talking about diagnosis, why, in your opinion, does it still take so long for women to get a definitive diagnosis of PCOS?
I wish I could answer that question, and I share your frustration. I spend a lot of time working with with Verity, the National PCOS Support Group. I gave, they held a meeting in Leeds earlier this year, and tomorrow I'm giving a talk to a whole load of GPs on PCOS. And I think people sadly, GPs, it's largely GPs, don't really understand properly what PCOS is, and mistakenly think that you have to have really severe symptoms that warrant being given the diagnosis, whereas we recognize PCOS as being a spectrum. As I said, it's a syndrome of different symptoms, the predominant ones being menstrual irregularity, signs of excess testosterone that I alluded to earlier, so unwanted hair growth, acne, sometimes thinning of hair on the head, and also disappearance of polycystic ovaries on a scan. You don't need to have all of those to give you the diagnosis. In fact, you only need 2 of those criteria. So a menstrual disturbance, signs of excess testosterone, or polycystic ovaries. So 2 out of those 3 gives you the diagnosis. And many women have mild symptoms.
So that the criteria you're referring to there is obviously the Rotterdam Criteria. And again, my frustration is that every woman should be assessed on this Rotterdam Criteria, but it doesn't happen.
It doesn't happen. I mean, I was at the Rotterdam consensus meeting that we held. That was in 2003. There was a lot of controversy before then about PCOS and whether you should include an ultrasound scan. Many GPs won't send women for a scan, so that sort of excludes a lot of people from the diagnosis being made. I mean, every gynecologist will send women for a scan, but a scan is a simple thing to do, and it shows lots of things, not only what the ovaries look like, but just checking that the womb looks okay, making sure there aren't any polyps in the womb or fibroids on the womb. So an ultrasound scan is a simple, cheap and helpful thing to do. And also you don't need to do lots and lots of blood tests to make the diagnosis. But Rotterdam was in 2003 and it's well established. When we held that consensus, I'm actually sitting in my office now looking at a photograph of about 30 of us from around the world who got together in Rotterdam to sort of agree the criteria for PCOS. We tried to keep it as simple as possible, which I think we did. It is simple, but of course there were lots of people who weren't included in that workshop, and they sort of say, oh, well, we didn't agree with it. But this new guideline that is what today is all about actually reinforces the fact that the Rotterdam criteria for the diagnosis of PCOS are the right criteria to use, should stay and don't need to be changed. The other thing is, you need to take a pragmatic approach to the management of symptoms. If you've got a woman with irregular periods who's wanting to get pregnant, you don't need to do lots of hormone tests. You just need one blood test will give you the answer as to why the periods are irregular. And in 90% of women with irregular periods, the diagnosis will be PCOS. So it's by far the most commonest cause of not ovulating and having irregular periods.
I didn't realise it was 90%. That's interesting.
Yeah.
So if people are listening and they're hearing you talk about these guidelines and Letrozole and the Rotterdam Criteria, and they go to their GP with this type of information, because obviously, our aim is to educate and empower people with the information we're sharing.
Yes.
Are the GPs, you said you're talking with them tomorrow, are they going to be receptive to this? Or, because obviously we're hearing more about patient power and there's all these different places online for patients to get access, from the fertility forum that you've mentioned to the podcast and to the show that we're doing today. Are the GPs going to be receptive, or do people need to go a step past and go straight to a fertility clinic and ask about this infertility MOT type tests?
GPs I speak to are receptive, but they're sort of self-selected because they come along to listen. And, you have to remember that GPs are confronted by every condition under the sun, and there'll only be some who are interested in gynecology. I think it's worthwhile just looking at the website of your GP practice and try to work out which GP in your practice has a special interest in obstetrics and gynecology. You may find that some have got a diploma in obstetrics and gynecology, so that will be DRCOG. That means that they've got extra training in obs and gynae, so that would be the GP in the practice who's worth seeing if you've got concerns about your fertility. But if you think you're getting nowhere with your GP, you're entitled to have a consultation in an infertility clinic, and that's again where you should ask not just to be seen in your local gynecology clinic, but to be seen by the gynecology team in your local hospital that's got the fertility clinic and an interest in fertility problems. And again, if it's not clear from the hospital website, and not all hospitals like ours have got an IVF unit, because most district general hospitals won't have an IVF unit, but they will have a gynecologist with an interest in fertility problems, and just ring up the gynae department and just speak to one of the secretaries and say, which of your consultants is interested in fertility? And then ask your GP to refer you through. And you are entitled to have a consultation with any consultant you want. So your GP is obliged to make that referral.
It's really useful advice. Thank you.
Adam, is there any new research currently into PCOS that's ongoing? Because sometimes I think that things don't happen for a while, and, is there anything that's happening at the moment that's of interest?
I think there's lots happening on the basic science of PCOS. So looking in more detail at the different hormones, looking at more detail in what's happening within the ovary to the egg, which is something that we're interested in, and the sort of the metabolism and genetic makeup of the egg for women with polycystic ovaries, and possible ways that can be influenced by lifestyle and diet. But these are sort of long-term projects. There's a lot of interest in the genetics of polycystic ovary syndrome, because it certainly runs in families. But there isn't a single genetic blood test. There's a lot of interest in ethnic variations, which again is something that we're very interested in. So, for example, women from South Asia are more likely to have problems with their insulin metabolism, and it's problems with insulin metabolism that leads to diabetes. And we do see ethnic and racial differences between different groups, which again is very interesting, actually. Things like PCOS run in families. So your first degree relatives, so that's your sister's mother, daughter, have got about a 50% chance also of having PCOS.
50%?
So I think 50%, yeah. So I think it's just worthwhile gently having a chat to your sister. If you're diagnosed with PCOS and you think your sister may be wanting to start a family, or just for general health advice, get your sister screened or your daughter screened, because again, empowered with that knowledge, you can then take steps to prevent worsening of symptoms. So, for example, I see lots of adolescent girls with irregular periods, some of whom may be developing PCOS. They're not interested in fertility, but that is a time when you can influence their knowledge about lifestyle and things that can make a difference to them in the future. So I think it's worth sharing knowledge, sharing information.
Fab.
Thank you, Adam. Really insightful, as always. I think there's a lot of information there. And we will signpost people to the various references that you've made in the show notes for this. And of course, those videos that you talked about. We'll make sure people know where to find them too. And thank you again for your time.
Yeah, thank you so much,
Thanks
Adam.
a lot. Okay, cheers then. Okay.
Bye.
Bye.
Bye. Wow, there was a lot of information from Adam there, which I'm sure made sense to you, Kate. I was scribbling notes frantically, and I must make sure we've got detailed show notes for this one, because we covered a lot of ground there, didn't we?
Yeah, a huge amount of ground. There was so much information, so much to talk about. I think if anyone is really struggling with any of that information or wants to find out more, then definitely Google the International Guidelines for the Management and Assessment of PCOS, because it gives you so much information that is so user-friendly to read through as well.
And just quickly, because it is PCOS Awareness Month, and you have a very gorgeous journal that you've created to help people kind of log their way through if they're having treatment or if they're just managing their PCOS, haven't you?
I have. So yes, to celebrate PCOS Awareness Month, I Along with Natalie from Barefaced Prints, who we spoke to in a previous episode, I developed a PCOS journal, and I have to say I'm really proud of them. They are absolutely beautiful, and it includes all my content, all my expertise, my tips, my advice that I give to patients with PCOS on how they can manage their PCOS better, lifestyle tips, things that you can do to really improve your symptoms and optimize your fertility. And it's got some lovely little quotes in and feel good factor as well, so it's a lovely journal. Lots of different things to do, like a symptom tracker, so you can look at your symptoms and monitor them, especially as you maybe put some of the things into practice that I recommend, and then see how your symptoms progress. So yeah, lots of information, and I'd be absolutely delighted to offer any listeners a little discount code. So if they would like to put in podcast 10 onto my website shop, then they'll have 10% off the journal.
So you can follow us both on Instagram to make sure you find Kate's website. I'm at Fertility Poddy, and what are you on Instagram, Kate?
Your Fertility Journey.
And make sure you're listening to the show next week. Oh, aren't they such a font of knowledge, the pair of them? And of course, Kate told you about that discount code for her gorgeous journals. They are really lovely, and I've been chatting with her through the process of making them, and I know she's really proud of them, so do support her. If it's something that you've been wanting to just get your head around a bit more with your PCOS, then something like this could be really helpful, or maybe a nice gift for a friend. The show notes for this episode are thefertilitypodcast.com/PCOS guidelines. Go and check them out to get Adam's details as well, and I'm going to share some other links to some useful things that Adam has been involved with. He mentioned the Fertility Forum videos. He's also part of the Fertility Education Initiative that have created some good videos too, so I'll link it all in there. Thank you as always for your support and for your review, because I know you're going to do that for me, and rate and share and subscribe to the podcast. I love it when you get involved. Doesn't it make you feel good that you've given something back to me if my little podcast has been at all helpful to you? We're just sharing the love, aren't we? Thank you as always for your support. And until the next time,